So the shoulder joint itself is a different type of joint as opposed to the hip, which is analogous to the lower limb. And the reason is you've got a very shallow socket in your glenoid, which is the articular component of your scapula. And then you've got a very large rotating surface on your humerus, which is the equivalent of the femoral component. In the hip joint, you've got a very stable construct with what's called an acetabulum that surrounds the proximal femur. But in the shoulder, the joint is largely a soft tissue joint comprised of the soft tissues, the capsule, the ligaments around the shoulder, and then very importantly, the rotator cuff tendons. So the rotator cuff is a group of 4 muscles that all arise from the shoulder blade and then insert onto the proximal humerus. And they have different functions depending on where they are. So your subscapularis muscle on the front of the scapula attaches onto your lesser tuberosity, and when your subscap contracts, you have an internal rotation movement. As opposed to your supraspinatus, which lies on the top of your scapula and attaches onto the top of the humerus. When that contracts, you get an elevation movement. And then the 2 external rotators, which are your infraspinatus and your teres minor, that attach onto the back of the greater tuberosity, giving you that external rotation movement. So you have in the shoulder joint not a very stable bony construct. The stability is increased by the capsule and the ligaments, and then your dynamic stability that comes from your rotator cuff. So not only does your rotator cuff provide movement strength, but it also provides a dynamic stability. And there's a very fine coordination between the muscles that externally rotate and the muscles that internally rotate, and the muscles that elevate and the muscles that depress. And when you get a break in that fine coordination, people start becoming symptomatic. Most of the problems related to the rotator cuff is that you have this bony process from the top of the scapula called your acromion, and underneath the acromion you have a limited space between the top of the humeral head, the tuberosity, and the undersurface of the acromion. And that's a fairly fixed space, and in that space you have to have your rotator cuff tendons moving and working smoothly, and that's where people get issues. Rotator cuff gets squashed and squished and injured in this area here, as well as the biceps tendon, which runs from the upper arm and has 2 tendons, the short head which attaches to the tip of the coracoid and is never a problem, and the long head which runs through the biceps groove and attaches to the capsule at the top of the shoulder, which is also vulnerable to instability and tendinitis issues on the shoulder.
Why does this happen? Why does all those structures get squashed, like you say?
Okay, so I always like to tell my patients there's 3 reasons why they're coming to see me for shoulder pain, subacromial pain. And I think that's a good definition to use, a subacromial pain syndrome. And it's a large umbrella term,
yes. And
then you can differentiate various aspects of that, either clinically or radiologically. So it's always a combination of things. So the first one I tell patients is there's something that you had no say about. So there's genetic tendencies, there's a type of collagen that you've got genetic makeup for. There is falls and accidents and traumas that you didn't control, you didn't have any say in it, and these things happen to you. So if you chose your parents poorly and you've got dodgy collagen, and you've torn your ankle ligaments and your knee ligaments, and you've keep doing your hamstrings and stuff, you're a sitting duck for rotator cuff issues. So if you're going to go start throwing javelins or doing hectic CrossFit, you are going to have problems.
Yes.
Then,
so sorry, it also depends on what you do. You might have this issue, but
yeah. So there's a genetic predisposition.
Yeah.
But if you go like I tell people, there's some people that could run comrades once a month and their knees would be fine.
Yes.
And there's other people that shouldn't run around the block because they just don't have the collagen makeup. Whether their collagen is too brittle or it doesn't heal or it's whatever. Okay, so the first aspect is stuff that you can't control. Your genes, trauma, etc. And the second one is mechanical. So the way that your whole shoulder girdle integrates its function. So the ability to get your arm up into the space requires everything from your back muscles, your scapular muscles, your rotator cuff muscles, and then your arm muscles to all work together to get that fluid, strong, pain-free movement. And when you get a break in any part of that chain, you start causing imbalances, and with imbalances, you overload some things and underload some other things, and that's when you start picking up either repetitive strain injuries or wears and tears. So, mechanical issues. For me, that's probably, in most people, that's the largest problem that they come in with. And as a surgeon, I can't do anything about that. That's where I see somebody and they've got a wonky scapula, or they've got a very poor cervicothoracic posture, or a very tight capsule, and I say, okay, well, you go along and you go do some rehab. And that rehab is depending on what the assessment is. If you've got your upper traps is way overactive and your lower traps are not doing anything, then we go correct that. If it's just a matter of you've got too much internal rotation and not enough external rotation, then we work on external rotation and correct that. So mechanical issues. And then the third large group, in my understanding, I don't know if anybody else uses this, but in my understanding is anatomical. So is there an anatomical problem? Is there a very, very curved acromion that has a hook of bone sitting there, and every time that patient lifts up their arms, they're impinging the cuff onto that osteophyte? No amount of physio or biokinetics or anything is going to correct that.
And there's different grades of that, hey?
Of the
acromion.
So I mean the acromion curvature is one thing, but it also depends how wide your acromion is. And does it slant to the lateral aspect? Is it very curved? How steep is the angle? So there's anatomical things that we always consider in somebody coming with shoulder pain. And obviously there you are dependent on some sort of an imaging modality to say, okay, look here, you've got a type 3 acromion with a big hook, and you can try all the rehab, but you're unlikely to respond. So in that case, I tell the patients, I can help you with that.
Yeah.
You still might benefit from seeing the rehab team, but in all likelihood, you are going to come back at some stage and say, no, I can't carry on with this, I need to do something anatomically. Okay,
and that's where you go and you reshape that bone.
So we do a decompression, and a decompression was typically comprised of 3 things, which is a clearing out of this subacromial bursa. In people that have had long-term impingement, the bursa gets very, very thickened. So the bursa is a little fluid-filled sac that we all have that sits between the undersurface of the acromion and the top of the rotator cuff. And normally it provides nice free movement patterns between your cuff and your acromion. But somebody who keeps pinching it, it rebels and it gets thick and it gets angry and it gets sore. So if you're doing a decompression, we typically do an arthroscopy. We remove that bursa, and it always forms again, but not pathologically. We assess the undersurface of the acromion, where the CA ligament is a ligament that runs from the tip of your coracoid to the undersurface of your acromion. And in somebody who's had ongoing impingement, that ligament will be very thick and usually frayed. You can see where it's been rubbing up. So you remove that CA ligament, and then you assess the bone, and you can see in somebody who's been impinging, they almost develop a little scalloped facet on the undersurface of the acromion, which we would then remove to give a flat profile on the acromion, so that when there is an elevation of the arm, there's no longer any impingement underneath that. The old textbooks talk about also doing an AC joint resection. In my practice, I only do an AC joint resection or a lateral clavicle resection if there was clinical and radiological evidence of symptoms related to that preoperatively.
Okay, great.